but that we've just passed under the 1 hour mark. So you have Melinda and I and a discussion left, and I will try and go a little light on the slides and data, because now that I feel that we're in a forum where we can speak easily and freely, I have to say, chairs, preparing for this, I wasn't sure how strictly I should focus just on the science, but I think the story behind how we developed our research studies and disseminated them is also important. As you mentioned, I was at WHO for 11 years, including sitting close to the IHR team. When we had the outbreak in Mexico, I was handling communications for the infectious disease team in Europe. And I heard a lot of those discussions, and as I was telling Melinda at lunch, we tried to respond to the disinformation in real time, one by one. So things were a little slower then, and bots weren't in fashion, and we were able to try and answer in a whole host of languages, the kind of false information that was circulating. And, something Dr. Chi mentioned, really struck me that, if China had shared all the information early on, maybe we would have been able to mitigate and eliminate this threat really before it went anywhere. What I was thinking, though, not knowing that kind of background in early January 2020, was that we do know what to do when we have an outbreak. Countries know how to respond, and I thought they were capable of respond. And I was quite vocal, saying there will be no announcement of a pandemic, because countries will react the way they should react, and use tried and tested response measures, and this whole thing will be over within a few months or maybe even a few weeks. So I'm sorry I was wrong. We all have the lived experience of what really happened. But during that period, I was speaking to an editor at Nature Medicine saying the same thing. And she said, well, why don't you write up what countries should do? And I thought, if I write this up and publish it with a lot of references, I'm really not sure it will have much traction. So I was talking to Scott Ratson, a distinguished lecturer at the CUNY Graduate School of Public Health and Health Policy. I'd met him in 1998 at the World Health Organization, and he agreed. He's a vaccine hesitancy expert. He agreed to co-author it, and we decided to ask our respective deans to co-author. At the time, his dean was Aymano Mohandes, who's here. I was still at the Barcelona Institute for Global Health. We asked a few well-known individuals, former ministers of health, the former commissioner of health for the European Union, and we published what we thought countries needed to do, and Nature Medicine encouraged us to make a checklist so countries could look at it and say, I am doing what I'm supposed to be doing. And just at the end of it, Scott Ratson said, why don't we add a couple of questions around vaccination? We could, for example, ask, and this is, remember, early in 2020, if a safe and effective vaccine is created, would you take it? And then we had a second question, if that were the case and your employer recommended it, would you take it? I thought, okay, we'll add those on, even though it's pretty obvious everyone will take the vaccine, but okay, we can ask. And that was the second time in a very short period of time that I was very wrong. And I'm glad we carried out that study, because it became the most cited study of Nature Medicine in 2020. Not just well cited, but also in media around the world, showing that if we do get a vaccine, which we did, but we need to be prepared for people who won't take it. And again, countries responded very differently to that. Some, as we just heard from Israel, really primed their population and were able to vaccinate almost every adult in the country, and many other countries did really a terrible job, as I'm going to show you now. I think I can skip through the background of the pandemic and go straight to the rollout. We've already heard about the speed of the rollout, which was a contributor to hesitancy, but I think Melinda might address this. This was really a lot. We already heard the background for developing these vaccines. This was really a lot of disinformation. These kinds of mRNA vaccines were already well underway as a platform of development. It just hadn't been rolled out so extensively yet. So what you see here is that for many people, the vaccine became a bit of a phantom for them. Year after 2020, we continued to survey countries around the world using representative samples so we could really comment on the country as a whole. You know, was the population willing to get vaccinated? And among those who weren't, why not? And we were able to analyze this by common variables related to education, socioeconomic status. Later we looked at rural versus urban, and as Dr. Mohandes will talk about tomorrow, we started adding more questions around trust in government, trust in health authorities, trust in doctors, family, and so on. What we see when we compare over 4 years is something that didn't often make the media, but you know, the global acceptance of the COVID-19 vaccine, although I thought quite low in 2020, although at the time we thought there would be herd immunity, so 70% seemed to be that magic number that would be okay. The numbers did increase in these representative populations each year, becoming quite high already in 2023. On the other hand, you might say, well, you know, 87.8% of the population wasn't vaccinated. One thing is you accept it, another is you actually go and get vaccinated for a variety of reasons, whether it's opportunity costs or access in your country, your city, your rural area. People didn't get vaccinated. But in spite of all of the disinformation, vaccine acceptance grew over time. That's the good news. Here you see it by country. It was quite low in some countries like Poland and Russia in the middle of this bar chart, and quite high in other countries, although, as mentioned, that doesn't mean they all got vaccinated, even if they accepted it. We thought that if you got vaccinated, you would almost surely, you know, get the booster. But again, at least early on, that was often the case. But later, maybe due to the so-called, you know, pandemic or vaccine fatigue, people were less likely to get boosted. I think if we did that survey now, people might even ask, why get boosted? Is there a booster? We've never been told about this, or we don't even know that it's important to do so. So we saw that kind of decline from over 85% to just over 70% from 2022 to 2023. And here you see the average for middle-income countries and the average for high-income countries, so a decline in both settings. We asked questions, you know, around the willingness to get accepted, to get vaccinated against other diseases. Here you see the global average, again, high-income countries and middle-income countries. And I think there was started to be a spillover in vaccine hesitancy with all the disinformation around the COVID-19 vaccine. We started to see people not being willing to get vaccinated against other diseases, some of which they might have commonly accepted earlier prior to the pandemic. So what are the impacts of vaccine hesitancy? Disease reemergence threats. Vaccine hesitancy heightens risks of reemerging infectious diseases, such as measles and polio outbreaks, and the impact on routine vaccination. We had major disruptions with infectious disease departments and hospitals, overwhelmed, whether it was in China, Italy, then Barcelona, where I was working, Madrid, onto New York and the rest of the world. We saw major breakdowns in the routine vaccination for other vaccine-preventable infections, and also the long-term public health risks, the ongoing vaccine reluctance, and also the compounding situation from people not recovering from the interruptions in their routine vaccine. But it's important to remember that before the pandemic, already in 2019, vaccine hesitancy was declared by WHO as one of the 10 greatest global health threats. So we can say a lot about WHO. When I worked there, we sometimes joked that they had two speeds, slow and stop. But they were definitely right about this being a major global health threat, and it just got worse once the vaccines became available. So Dr. Mohandes will speak more about this tomorrow, but we've been looking at the role of trust and trust building in immunization programs, and WHO has a nice behavioral and social drivers framework, which identifies key behavioral and social drivers that influence vaccine acceptance effectively. This is around perceived disease risk, various social processes, social norms, all of which contribute to an individual's motivation, and then are all the practical issues around availability, affordability, ease of access, service quality, and respect from health workers, and that ultimately leads to the uptake of recommended vaccines. So there's a lot that contributes. There's also a lot of places where those who are opposed to vaccination can intervene in the thinking, the feeling, the processes, the motivation, and so on. So other factors influencing vaccine hesitancy include safety concerns. Even with strong safety data, safety concerns were regularly raised. I was in Denmark during part of the pandemic, and when we had the first death in Norway, countries across Western Europe said, let's stop vaccinating in all of our countries. Meanwhile, there were plenty of deaths from COVID-19, but the one death from the vaccine got a lot of attention. The spread of misinformation, which will be addressed, but we have to remember that there's different kinds of false information, misinformation, disinformation, and malinformation. Some of it is accidental spread, some of it is very intentional spread, and we need to look at who is spreading that. Michael already mentioned groups in the US influencing Israel, but we also had groups in other parts of the world, Russia, China, and other countries that were intentionally spreading false information to create disruptions in economies, in education, in the social workings of countries. A distrust towards authorities. Again, we heard that where there's a lower sort of trust in government, and we'll come back to this tomorrow, there often was a lower trust in vaccines and an unwillingness to get vaccinated. But what can we do about this? Luckily, there's a large body of evidence about how to improve vaccine acceptance, because vaccine hesitancy isn't new with the COVID-19 pandemic. It's just become quite accelerated. So to be as transparent as possible with clear, honest messaging about vaccine benefits and risk, and the risks builds essential public trust in healthcare. Community engagement involving local leaders and trusted figures enhances outreach efforts, fostering acceptance through relatable narratives, logistical support improvements, and addressing the barriers such as transportation and accessibility. So, considering misinformation, this is, the false or misleading information spread unknowingly, and that affects public perception during crises, while disinformation involves the intentional spread of false information aiming to deceive and manipulate public behavior. Both of those undermine trust and compliance with health directives in non-emergencies or emergency situations. Social media partnerships have become incredibly important. I was mentioning at lunch that when I first started working on these issues in 2009, I went onto Twitter and I simply took the name immunization, and we used that to counter false information where we could actually see online that someone said something that was incorrect about a vaccine, and we would just write a response to it. That's impossible now with the speed of false information. On the other hand, things can also be automated. WHO has played an important role in addressing false information, and they've had a great pandemic response and a whole program around what they call the infodemic. But these kinds of collaborations with platforms are very important, and we saw, critique of Spotify, critique of other, platforms that were unwilling to regulate the information that was on their platforms. And I think that's one of the ongoing issues, is how do we control what kind of information is out there, particularly during a pandemic. If this were related to stocks and private companies and you shared insider information, there's a pretty good chance you would end up in prison. But if you spread false information about vaccines that can lead to entire countries being shut down, nothing really happened to you. So we need, in addition to that kind of social media partnership, evidence-based campaigns, implementing campaigns grounded in scientific research and constantly going back to the research, to the solid research, to citing it. We already heard from Slim this morning, there is Dr. Google out there and the University of WhatsApp and their PhD programs, but we do have, an important peer review system, and we need to not forget that we can constantly go back to citing that kind of evidence, even if people are coming, at us with false information. And again, we have to think about how much we want to really engage misinformation, head on. So at WHO, we decided to respond, to each message. And here during the last pandemic, WHO issued regular updates as well as print material to how to respond to false information. There were debates on TV, on the news, and so on. But we have to think, the balance between giving a voice to false information, but also if we ignore it, we see what happens. It just spreads virally. So some of the roles of health agencies, again, we heard already about the CDC and WHO and the switch between using masks and then not using masks and then using masks, but the agencies remain really our leading body to address this. They can disseminate accurate information in a timely way. They can lead to targeted communications, health literacy improvements, coordination with other entities. They combat misinformation. They share data. They get feedback. They engage. And when done well, they're also training and building capacity. And we saw some of that happening with training religious leaders, training people in the community. So I think there's an incredibly important role for health agencies, but we also have to work with them to make sure that they're on message and responding in a timely way, because as we saw during the pandemic, as people lost faith in some of those agencies, vaccine acceptance also fell. We've talked plenty now about vaccine equity, so I won't really dwell on this issue other than that there was an inequity, among countries, but there was also a huge inequity within countries where we saw poorer or more rural populations not having access to vaccines in a timely fashion and not having the support they needed to get vaccinated. We talked a bit about COVAX, and there was also a question earlier about who can lead these efforts. I think COVAX was an unbelievable development with incredible potential, but countries then need to fulfill their commitments, not just their funding commitments, but actually the delivery of vaccines that they've committed to such kinds of institutions, and avoid that kind of vaccine nationalism that we saw all over the world. And I've already mentioned the geographic disparities. Let me close just by telling you that after our third vaccine hesitancy study, we went from the 2 questions to I think 35 or so questions. We had questions targeting healthcare providers. We had our general questions. We started looking at trust. We started learning a lot about vaccination and vaccine hesitancy. And during this time, I was waiting for the World Health Organization to come up with the plan, the pandemic action plan or strategy to end the COVID-19 pandemic, or what we called the public health threat, borrowing language from WHO that they use for viral hepatitis, where they don't say they're going to eliminate it, but they're going to eliminate viral hepatitis as a public health threat. They're going to end other diseases as a public health threat. So we defined what a public health threat was, and I brought together experts from around the world. Some of you are in the room, and thank you for joining this effort. Many people asked, well, what exactly are you trying to do with this kind of plan to end the pandemic? And I said, let's take the main domains, whether it's geographic, whether it's disparities, including geographic, whether it's vaccination and other prevention measures, treatment, and so on. Let's have a review of the evidence, an evidence review for each of these domains, and let's come up with a set of recommendations that we can have a consensus process to identify But rather than just be a group of experts who publishes another set of recommendations, let's do two things. Let's present both, and here we expanded from 40 to 364 co-authors. Let's both present the percentage of disagreement, because even when you have 10 people, if one disagrees, it often doesn't come out. Maybe you see it in the discussion if you read that, but you don't see it in the results. So we know there's a lot of disagreement. Let's engage those who we don't necessarily agree with, and then let's present the recommendations in terms of agreement and disagreement and discuss it. And then let's expand from a core group of 40 experts and try and reach experts in every country possible. And eventually we reached people from 112 countries and territories who agreed to be part of this huge effort to develop a plan. At any time I was waiting for WHO to release their plan, and I tell everyone, I'm so sorry to have wasted your effort with all of these phone calls, with all of these Delphi rounds, but WHO did not come up with their plan. So ultimately, 386 people were involved in this effort. Some of them were at very high levels of their government and asked not to be named, but the other 364 are listed as co-authors. And I won't go through all of this plan, just to say it was ultimately published in Nature. It got a lot of attention, but we focused on vaccination as one of our 6 areas, so I'll just very briefly go through what some of those key recommendations were. But here you can see the different domains of health systems, prevention, communication, pandemic inequities, treatment and care, and vaccination. So here's just the top half of the recommendations, very difficult to read. In the end, we held a ranking exercise as well and said, this is what experts from around the world think you should do, and this is really the priority actions to take. And then you can go through the paper and you can see both the top 10 overall recommendations, and you can see the domains on the left. You know, no one domain dominates. This was a health systems issue. This was a communications issue. This was a prevention issue. This was a vaccination issue, and so on. And often we saw the response in countries just focusing on one issue in particular. I was spending a lot of time in Spain as well, and it was always the chief epidemiologist who came out each day and would say, these are the numbers of new cases, and no one else from the government really showed their face. In Denmark, the entire government came out and said, this is why the borders are closed. This is why children cannot go to school. This is why you need to get vaccinated. 2 very different approaches, building a lot of trust, having discussion in Denmark, and a very top-down approach in Spain, which we saw was a real failure in terms of their response. The third ranked recommendation was around vaccines, and this was the call for a vaccine plus approach. This was first published by a group of experts in the BMJ, many from the United Kingdom, and they said, we're not going to get out of this just through vaccination. We need other kinds of prevention measures, as well as treatment and financial incentives. So Michael, you mentioned, the importance of providing food. I know in the UK, when they were providing donuts, some of us who work on fatty liver disease were thinking, well, okay, fine, eat a donut just and get vaccinated and then go back to eating healthy food. But whatever it takes, we're in the middle of a pandemic. But I think the vaccines plus approach is the cornerstone, both when we have vaccines, but also even when the population is vaccinated. There's so many other things we need to do at the same time. The take-home messages around vaccination were that they were effective tools against COVID-19, will not alone end COVID-19 as a public health threat. And I won't go through all of the issues, but here are some of the limitations, and we need to be very open about what the limitations of vaccination programs are. But here is what a vaccines plus approach can consist of: testing, surveillance, treatment, community engagement, and the implementation of social prevention measures and structural interventions and financial incentives, as mentioned. So addressing vaccine hesitancy means mitigating vaccine hesitancy through improved health literacy, enhancing community resilience against pandemics. We can't do this at the national level. We need to go into communities wherever they're located and work with them on their terms. That's time-consuming, That can be expensive. I think your example, Michael, from Israel was great. It means block by block. We might need to change the language and we might need to change the messages, but that often wasn't the case in countries that had sort of a one message for everyone, and that really didn't resonate with everyone. Equity is the cornerstone of public health. It needs to be the cornerstone of vaccination programs, both within countries and among countries, and we've already discussed that and the challenges we faced. And future pandemic readiness. I mean, I dare say if we went around the room, maybe we would need to do it anonymously, but how many people feel we're really ready for the next pandemic? Do people know what to do if there is a new pandemic? If it's airborne, do we have masks well produced? Do we have the vaccine production capability? Are countries ready to collaborate? When I've been following carefully the pandemic treaty negotiations, and one of the first things that fell by the wayside was the enforcement mechanisms, and it's getting more and more watered down. Around the world, we do have global collaborations that are enforceable. We have a World Trade Organization. You try and break a patent, people will come after you. We even have a World Tobacco Treaty that means that WHO will walk out of meetings if organizations have received funding from tobacco. There's a lot of other parts to that treaty, but we can have health treaties that have teeth and that are effective, and that's what we're really going to need if we're going to be ready for the next pandemic. So let me end there. Thank you.